Well, I will treat astigmatism up to about 3 diopters of cylinder magnitude. And I will choose from a variety of procedures based on the cylinder magnitude and axis. And any one of about 5 different options are available to me. And I'll start with a low cylinder patient and work my way up for purposes of this discussion. But I will use a clear cornea incision on axis for anybody about 3/4 diopter, and that's at the steep axis. I'll put the clear cornea incision. Anybody about a diopter, I will use paired clear cornea incisions on the steep axis. And a diopter and a half or more, if it's with the rule, and it's up to 3 diopters, I will use a modified scleral tunnel procedure that I call scleral recession. And I will locate that scleral tunnel anywhere from about 75 degrees to 135 degrees on the steep axis. And I will modify its chord length on the external incision. And on the internal incision, it could be anywhere about 3 millimeters, the external about 6 millimeters. So I essentially have a trapezoid that we're starting with. And I will use the scleral tunnel to insert the ICL. And once that step is completed, I'll re-inflate the anterior chamber to appropriate intraocular pressure. And with the aid of an intraoperative keratometer, using the light reflex that generates, that initially is an oval of some degree based on the pre-existing astigmatism, I will then modify the internal lip of the scleral tunnel with a keratome and make it a little bit bigger, maybe 3 to 4 millimeters. Then I'll reinflate, check to see if I got an oval or a circle. If I'm getting closer to a circle, I stop. If I still need a little bit more, because it's still too much of an oval, I'll make it a little bigger. And I'll incrementally do that, so maybe I'll have to open it the full amount, 5 or 6, or less. So I've been very successful using that technique. It's very stable, it's very reproducible, and it doesn't regress in older patients, but in younger patients with more elastic sclera, it may regress a little bit. But the other benefit of that procedure is the lamellar procedure. Unlike a limbal relaxing incision, which is a vertical incision in the cornea that never fully heals and may progress with time and not be stable, this is a very stable procedure. And it does not induce corneal spherical aberration like the excimer laser will do. Now, on the other hand, if you have an against the rule patient with a significant cylinder magnitude, then I have to use a staged excimer laser procedure, which has the disadvantages of it's another step, it's another layer of cost, and it will potentially increase corneal aberrations as much as 200% of the baseline.